Hello, everyone, and welcome to the Dizziness 101 lecture. This lecture is intended for my emergency medicine class. So for those of you out there, we're taking an emergency medicine look at dizziness. The first thing to start with is definitions. This has been classically the way that we have organized all of our differentials as medical professionals. We talk to the patients about what they mean when they say dizzy. Did they lose consciousness or pass out? That's syncope. Do they have muscle weakness and they feel like they're going to fall? That's going to be more weakness. Typically, the three most common pathways that people organize dizziness into is going to be vertigo, lightheadedness, and disequilibrium. And when people say the word vertigo, they mean spinning, like the room is spinning around the patient. There's motion when they're still, and this usually leads to quite a lot of nausea, sometimes even vomiting. Lightheadedness is more of the syncope type, the almost going to pass out, their vision starts getting dark or black, and they may or may not have weakness associated with the lightheadedness. And finally, disequilibrium. Disequilibrium specifically refers to things like balance or coordination problems, where they feel like they're off balance or they don't know where their limbs are in space. This organization tends to be how a lot of folks organize all of their differentials. And it's really important for documentation purposes that you at least attempt to ask the patients to clarify exactly what they mean when they say dizzy, because unfortunately, the English language gets really complex. So for documentation purposes, for differentials, and for lectures, this matters. However, and this is an example, I'm sorry, of three of the different ways that they divvy these up. Now, we're going to be talking about a lot of these things, so don't worry about this right now. But in clinical practice, when you're asking a patient, what do you mean when you say dizzy, especially in English, the patients have no idea. They don't know the difference between vertigo and lightheadedness. And even when you explain it to them, if you ask them multiple times, their answers will be very inconsistent. If you ask in general, these are just a few of the descriptive words that I've had patients tell me before. Things like, I feel a little bit dippy. That doesn't really help me when I'm trying to figure out which differential pathway to go down. Or if they tell me that I'm feeling just not right. There's another one that really frustrates a lot of medical providers. So while it's really important for your documentation purposes to kind of choose a verbiage and go down that pathway, you need to understand that in clinical practice, this always isn't very easy. A lot of times patients can't really define what their dizziness actually means to them. So that means that you have to have a broader differential with dizziness than you otherwise would have. Another reason why so many providers really don't like dizzy patients. So let's talk in specific about the most classically tested, the number one most classic cannot miss diagnosis for dizziness patient. Because this is so classic, because everybody tests on it, it's also one of those things that are considered standard of care not to miss. This means that for documentation purposes, you need to have verbiage and address this with every single dizziness patient you see. And that is a posterior cerebellar stroke. This we kind of refer to as a haystack diagnosis, because if the haystack or the straw in the haystack is every different kind of cause of dizziness, the needle in the haystack is going to be the posterior stroke. And it happens just about as infrequently as does a needle in a haystack. And it's also just as hard to find. So that said, you still need to know about it, and you still need to have your appropriate documentation to prove that you've thought about this diagnosis. So you're looking for a specific complaint of dizziness with some kind of neurological finding. Now, where and what neurological finding can get pretty picky and specific. The three most common triad, they call it the 3 Ds, are going to be dizziness, diplopia, and dysphagia. That said, just like all other triads in medical profession, it's not very common to find all three in one patient. So instead, what I want to do is kind of explain to you what is the posterior area of the brain and then go through all of the general symptoms of each area. So remember that usually this stroke is going to be a clot. And where the clot is and which part of the brain it's affecting is going to determine what kind of symptoms you're going to have. So the most common and the most classic is going to be your cerebellum. But you can also have symptoms in the brainstem or in the occipital lobe. So the cerebellum is primarily responsible for coordination of your body, right? It's kind of what we learn as we're walking or moving or feeding ourselves. And so you're going to notice symptoms if the problem is in the cerebellum with coordination. This is not going to show up on a typical neuro exam unless you specifically test these things. So I'm talking about gait abnormalities, specifically ataxia, the finger to nose, and somebody needs to be moving the finger around while the patient is doing finger to nose. And then they have to do the other side, right? And then heel to shin. And don't forget that you're comparing it bilaterally, right? So one side might be off or both sides could be off. Next is the brainstem, and the brainstem specifically is going to be the pons, and it's going to be the area that is responsible for involuntary functions. This can make it very difficult for the patient to explain what it is they're experiencing, or maybe they don't even notice the symptom there. Stuff like a problem with handling their own body temperature, where they have really high body temperature, really low body temperature, or problems where they can't stay asleep or they can't stay awake. Somnolence is very common for brainstem strokes. That's where we get the locked in syndrome. And occipital lobe is the primary area where our brain interprets what our eyes see. So we're talking about visual symptoms. A lot of patients with occipital lobe problems are going to talk about double vision, blurry vision. One eye might be worse than the other, and they're probably going to have some nystagmus. Now, all three of these are probably going to get dizziness, and all three of these are probably going to have nystagmus. So it's really important that you understand that dizziness and nystagmus is very nonspecific when it comes to posterior stroke, kind of like all the rest of these symptoms. So you want to specifically document normal gait, normal finger to nose, is able to be awake, normal body temperature, normal vision or blurry vision or double vision, that kind of stuff. I've also included a couple other extra symptoms down below, like nausea, vomiting, headache, neck pain, and Horner syndrome, because that can also go along with having some sort of blood clot in the posterior stroke area. So, things to know about posterior stroke. This is a picture of an MRI, by the way. Posterior strokes are notoriously subtle and hard to find. That is why that you need to document all of those very specific neurologic findings that we just talked about. You also want to understand that ataxia doesn't just apply to gait. Doing or looking for gait ataxia can be really difficult, especially in our older patients. Some of these patients require walkers and they have an abnormal gait to begin with, or they can't stand. If that's the case, you can do a truncal ataxia evaluation. That means that you try to sit the patient up and see if they can hold themselves still without help. This can also be a really difficult test to do because some patients, especially if they're bedbound, they just don't have that musculature to hold themselves up. And it can be really hard to differentiate between muscle weakness and actually a coordination problem where they can't coordinate and hold themselves up. But it can be worthwhile to test on some patients. I also want you to know that posterior stroke is mostly caused by blood clots, right? Thromboembolism, at least 58% or higher. But some of these can also be caused by either bleeding or by arterial dissection, specifically vertebral artery dissection. So if you're worried about a vertebral artery dissection, which we'll talk about here in a minute, you want to get a CTA or a CT angiogram of the neck. That's going to show us the dissection and hopefully reveal our cause for our posterior stroke. Now, I want you to notice that posterior stroke in CT heads only shows up about 7% of the time. That is pretty terrible. So a CT head is utterly useless when we're looking for a posterior stroke. We're going to come back to this topic and talk about it a little bit more, but it's really important that you know a head CT is not going to show posterior stroke. As a matter of fact, most posterior strokes require an MRI to find, as you can see in this picture accompanying this slide. That means that if you're suspicious and you think, there's dizziness and there's visual symptoms, and I'm thinking that there's some coordination issues, you should probably go ahead and page out a code stroke, call your neurologist, or initiate a transfer, especially because the TPA rules are giving within 4.5 hours. And some people, according to neurology standards, are trying to make this time longer, specific for posterior stroke, because posterior stroke deficits are so devastating to the patient. So I want to bring up Wallenberg syndrome, and I don't want to do this to torture you with neuro, but what I wanted you to understand about Wallenberg syndrome is the most common cause of Wallenberg syndrome is a vertebral artery dissection. Most of the time, and I won't say all, but many times, if you have a vertebral artery dissection that's been there long enough to cause symptoms, you get Wallenberg syndrome. Wallenberg syndrome is the occlusion of specifically this artery or the posterior inferior cerebellar artery due to a dissection. And this particular syndrome you can see with exam. And that's why it's a really good one to know, because it's a lot easier to identify if you know what you're looking for. This is going to cause some nausea and vomiting. It's going to be very acute onset. It's going to involve loss of pain and temperature on the other side of the body. And it's going to cause something called Horner's syndrome. One of the easiest things to identify in Horner's syndrome is something called ptosis. Ptosis is the drooping of the eyelid. Now, you can notice here in this picture of Trump that there's some ptosis going on over here in this eye. That said, the way that I can tell this, especially with our older, maybe more wrinkly or more obese patients, is look at where the eyelid crosses that pupil. Notice that the eyelid doesn't touch the pupil here, whereas the eyelid is definitely touching the pupil in the other eye. That's how I can tell the difference between a wrinkle and actually having ptosis. If the patient has ptosis and dizziness and all of these other symptoms, I would probably be ordering that CTA sooner rather than later. And I would also be contacting neurology to page out that code stroke even before that CTA was back. Wallenberg syndrome in specific, if you happen to find it, is treated with TPA within 24 hours after the blood pressure is lowered, because the daily life disruption is so significant. This is a very unusual way to treat a dissection, because most dissections aren't treated with TPA. Again, this could change later, but for right now, this is what I can find. Oh, here is some explanation of Horner's syndrome. They talk about loss of sweating on one side of the face, a small pupil, and that ptosis or that drooping eyelid. Really, it's very hard to see whether somebody is sweating on one half of their face or not. So a lot of people depend on the pupillary changes and the drooping of the upper eyelid. Now let's talk about vertigo. There are two main types of vertigo, or at least two classifications. So the first one is peripheral, which means outside the brain, and then central, which means something inside the brain. These are different and they present differently, which is very handy. So when you talk to the patient, one of the things that you need to pay attention to is onset and how dramatic the symptoms are. So if it's been kind of subtly increasing slowly over time, and it's been pretty constantly dizzy, but the patient is managing, that is a big indicator that this might actually be something wrong with the brain. Of course, the brain is tricky, and remember that it doesn't always notice its own problems. which is why it's really important and hard to notice central causes of vertigo. Peripheral causes, on the other hand, are big, they're dramatic, they're intense. These people can't walk down the hallway, they're vomiting like the exorcist all over the room. This happens suddenly, exactly an hour and 15 minutes ago, and the dizziness comes and goes. Now, the last bit on here that I want to mention is the fatigability. And I'm specifically mentioning fatigability when we're talking about nystagmus. When you have vertigo for both of these causes, the patient has nystagmus. Now, the nystagmus, if you have somebody look to this side, their eyes are going to beat a little bit. That is the definition of nystagmus. But if you keep having them look, eventually it'll either slow and stop, and that means it's fatigable. That is more indicative of a peripheral problem than a central problem. If, however, the nystagmus continues, I'm going to say for at least over 30 seconds, then that is probably not fatigable, and it definitely indicates that it's a bigger problem, it's a brain problem, and we need to pay more attention to it. So, like all things in life, and maybe even emergencies, the bigger and more dramatic it is, probably the less serious it is when it comes to vertigo. And the harder it is to find and the more subtle, the bigger deal it becomes. Now, of course, for patients with nystagmus and vertigo, a lot of neurologists got together with some emergency medicine doctors and kind of came up with something called the HINTS exam or the HINTS test. HINTS stands for these 3 tests. And if these 3 tests are done, this is very reliable and very indicative of some serious abnormal problems. This is a way to determine if it's central or peripheral. Again, you can see that from the table down there in the corner. So the HINTS exam is something that I recommend you Google, or if you're in my class, you know that I've already assigned several videos of people doing HINTS tests with both a negative and a positive test. So you will get a chance to see this in real life shortly. But the HINTS test stands for the head impulse test, the nystagmus test, and the test of skew. So the head impulse test looks really confusing, but what you have to know about it is it's been essentially like doll's eyes. So you're taking the patient's face and you're just moving it around, seeing that if their eyes stay on you, no matter where their head moves, if it does, that's normal. If when you're moving their head and their eyes like turn with their head and then they suddenly have to snap back, that's an abnormal test. For nystagmus, remember that we're doing HINTS exams only on patients with nystagmus. So we already know that nystagmus exists. What we want to pay attention to is how. Is it on one side or the other? Is it vertical, up and down? Is it horizontal, side to side? Is it rotary, in a circle? And is it fatigable? And then finally, there's test of skew. Test of skew can get really complicated, and I think really watching the video makes it more sense. So I'm going to leave that to the video. Important parts, though, are you knowing how to interpret a HINTS positive and a negative, and being able to report on each individual part of the HINTS exam. Here's a video in case you want to see a positive and a negative exam. And again, I've assigned several different topics. Another way that a lot of emergency medicine folks like to determine whether this is a central or a peripheral, and specifically whether or not they need to treat it like a stroke. A lot of the neurologists got a lot of pages about dizzy patients, thinking that all of the ER doctors were paging out code strokes for dizziness. So they came up with this question, this 5-question in blue. And they said, if there's an answer yes to any of them, go ahead and call code stroke. Treat as if it's a stroke for right now and keep your other differentials in the back of your mind. However, if all of these 5 are no, then you should probably go ahead and treat it like BPPV or vestibular neuritis. Finally, I got to talk about other causes of dizziness and the workup of dizziness. So, if you listen to any of the talks or you read any of the websites when we talk about dizziness, dizziness is kind of a big, wide ranging topic, lots of differentials, and a lot of people talk about a lot of complex differentials, things like BPPV or labyrinthitis, all of which we're going to talk about today later in this lecture. But what I want to mention in real clinical practice is that while it's good to keep these differentials in the back of your mind, and that's how the emergency medicine doctor thinks about things, that's how the practitioners work as we think about the things that could kill you first or the things that are most likely, it is important for you to know that not all patients who are dizzy needs a dizziness workup, I guess. Let me explain. If you have a patient who's coming in who just feels dizzy, can't quite explain it, but you know that they're a diabetic, one of the most obvious causes of dizziness in this patient is a low blood sugar. So you should probably get a point of care glucose. You don't necessarily need to do a workup for BPPV or a posterior stroke, right? We need to remember that common things are common. And dizzy patients, especially in this case, don't always need a big dizziness workup. One of the most common causes of dizziness that I've seen in my personal practice, especially in the elderly, is dehydration. Sometimes that means that the patient just wasn't drinking enough, and sometimes it just means that they had 8 cups of coffee that day. So it's always handy to do something like the orthostatic vital signs and pay attention to whether that blood pressure is a little bit soft, right? Simple bag of fluids can make all of the difference. Again, that patient didn't necessarily need a big dizziness workup. So I've included here what I'm going to term mimics, but they're all non-dizziness workup patients that have dizziness. Patients who have fevers often complain of being lightheaded or dizzy or even of having headaches. But when you treat the fever and their temperature goes back down, they don't have dizziness anymore. So I didn't need to do a big dizziness workup. Same is true about getting a point of care pregnancy test, right? We know that pregnant women sometimes first initially present by passing out or saying that they're dizzy. Another big one that is very common is a patient who has very big dramatic dizziness and they end up having an eardrum perforation, either from trauma or from an infection. Again, something to look for. And remember, dizziness is the second most common side effect of all medications. The first being nausea, the second being dizziness. So maybe they've just started on a new medication. Always ask a lot of these questions. Be aware that lots of other things exist beyond just the typical dizziness workup patients. I also want to bring up to you the idea of ordering useless tests. Dizziness in particular has come under attack by a lot of insurance companies and hospital systems, and they're watching very closely the practitioners and what they're ordering for dizziness in specific. Because the differential is so big, and because healthcare costs are so big, what they're looking at is patients specifically with dizziness, and they're trying to see how many tests that practitioners are ordering. Remember that I told you that one of the biggest do not miss diagnoses is posterior stroke. And yet so many patient providers, when they have a patient who comes in with dizziness, orders a head CT. Why? They specifically document a normal neuroexam, so a tumor or brain bleed or hydrocephalus is very unlikely. And if that's the case, and the patient isn't confused, why are you getting a head CT? Especially when you know that even the worst case scenario, the head CT wouldn't show anything. It doesn't mean that you never order a head CT. There are specific reasons to do so, but make sure that you don't just randomly order things because that's what you've been told to do. Actually think about why you're ordering this. Same would go, say, for example, with a troponin. The number of times that we see like a STEMI patient or an NSTEMI patient who presents with a primary complaint of dizziness is really low, especially if we see an obvious cause like low blood glucose or a perforated eardrum or fever. Do you really need to get that troponin? I'm not saying never do it. I'm just saying make sure you think about it before you instantly order something. Remember that associated symptoms with the dizziness can help. Just like I talked about the neuro findings of nystagmus, remember to ask about questions like headache, neck pain, chest pain, palpitations. Some of these are big deal causes. Things like arrhythmias can cause dizziness, and we don't want to miss that. But so can things like a panic attack, right? Or hypotension, for example, just because somebody is dehydrated. So don't forget to ask about associated symptoms and try to combine a lot of your differential lists with all of the associated symptoms that these patients are having. Now, I've organized for you kind of a little map of what I want to go over today. And I've differentiated peripheral causes of vertigo with central causes of vertigo. And from there, I even differentiated them into further lists. Peripheral causes can either be from the inner ear itself or that vestibular nerve that goes to the brain. And central causes could be caused by vascular issues, mainly strokes, or by non-vascular issues, problems with the brain like a vestibular migraine, multiple sclerosis, tumors, brain bleeds, that kind of stuff. A lot of that central stuff we go over in our neurological section, and that happens in second semester. I'm going to leave all the talks for central vertigo for that time. What I want to talk to you about today is the peripheral causes of vertigo. So let's start with problems of the inner ear. Problems of the inner ear are all going to be associated with the vestibular system. So that means that we're involving our semicircular canals, which are filled with endolymph, which is essentially a fluid that our body is making. And it's connected to the cochlea, which looks like that snail shell situation that you're seeing. That's where we're hearing all of our little tiny hairs that help us differentiate high pitch versus low pitch. And finally, our vestibular nerve that carries all of that information to the brain so we can hear and we can also know where we are in space. So BPPV is the most common cause of vertigo when we're talking about real dizziness vertigo. And luckily, the name tells us everything we need to know. Benign paroxysmal positional vertigo. Benign means not malignant. It means it's not scary. It means it's not going to kill you. It also means it's not an emergency. Paroxysmal means it came from out of nowhere, and it also means intermittent. And then positional means that head movement specifically makes it worse. So if you stay still and the vertigo gets better or the dizziness gets better, that's probably a big indicator that it might be BPPV. And finally, vertigo, and that's that sensation of room spinning or abnormal movement. That room spinning can be pretty dramatic, and it can still cause nausea, and plenty of times it can also cause vomiting. Typical episodes last about a minute, although I have seen plenty that last a little longer. And BPPV itself can last weeks. It also can recur even when you think it's gone away. Now, to understand what it actually is, let's look at this graphic. So we see our semicircular canals, and it's full of that endolymph fluid that we talked about. Inside the endolymph are these tiny little stones called otoliths. Otoliths are going to settle wherever gravity makes them settle. So let's say it's on the bottom of the semicircular canal. That information is going to be taken to the brain, and that's how we know where our body is in space, even when we close our eyes. So if you closed your eyes and I took you upside down, you would still know that you're upside down, even if your eyes couldn't tell you that, because of these semicircular canals and these tiny little otoliths. Now, the problem becomes when one otolith on one side gets either stuck or out of sync with the other side. If one side is telling me I'm sitting down and not doing anything, and the other side is telling me I'm upside down and it keeps moving, you can understand how my brain would get confused. It would interpret that sensation as dizziness, and it would make me very nauseous and probably vomiting a whole lot. This is a pretty radical understanding of what our body does to understand where we are in space. So we use two different maneuvers to really figure out BPPV. The first one we use to diagnose BPPV, which is called the Dix-Hallpike maneuver. And then the second one that we use to treat is called the Epley Maneuver. Because these get confused so often, they're very easy to test. And it's something I want to go over so you can actually do these in practice. So let's go with the Dix-Hallpike maneuver. This is how we diagnose BPPV. So you can see from the pictures that what we want the patient to do is sit on the table. You want to explain what you're going to do before you actually do it with the patient because you need their cooperation. I would also recommend that you have a vomit bag because this often makes patients who are positive throw up. So what you're going to do is you're going to hold their head, you're going to have them fall back to the exam table with their head hanging off the exam table. Notice that the head is tilted very posteriorly, and then you're going to turn their head to the side very quickly. This whole movement is going to happen very quickly. So they're going to fall back and turn their head very quick. You also want to tell them to keep their eyes open because what you're looking for with a positive test is instant nystagmus when you move their head. Notice that you're going to have to do this twice, once to the left and once to the right. And one side of nystagmus is going to be considerably more. That's going to be the side that is the problem. Now, I also want you to know that this is specific to the posterior otolith. So if you have a otolith that is out of sync in the anterior side, this is probably not going to end up being positive. But as of right now, we don't have a test for the anterior or the other semicircular canal. So it's only going to be for the posterior. Now, the Epley maneuver, if the Dix-Hallpike was right, is going to be able to fix your patient. This is a big deal because they don't have to take a shot or anything else. They just have to do a series of movements to get those otoliths to go back into the appropriate position. That means that they can do these at home, they can do these with you in the emergency department, or they can do them in the ENT office. Now, which side you go will depend on which side the Dix-Hallpike was positive. And the good thing about this is, while you can do this once in the emergency room, most likely they're going to have to go home and do it again. It's important that you tell patients that some patients do get better with the first time, but often patients require 2, 3, even 4 times before they get better, which is why I like to Google Epley PDF and send the patients home with a picture graph of an explanation of how to do this at home for themselves. Now, Menieres disease is another peripheral problem. Menieres disease comes with a triad, which again, remember, it's not always the initial presentation, but it's going to be the vertigo with this ringing in their ear and some hearing loss or deafness on that side. Menieres disease is a pretty serious situation. Think of it as glaucoma of the ear because there's too much endolymph fluid and it's expanding and causing those otoliths to go wonky on that side. Unfortunately, Menieres disease is progressive, and as of right now, we don't have any cures for it, which means that eventually they're going to lose hearing in that side of their ear. These people do not have problems with different positions. It doesn't change no matter what position that they're in, and these people need to follow up with ENT. However, it's important that you know that we in the emergency department do not and should not be diagnosing Menieres disease. So you can tell a patient that you have a suspicion for it, but remember to always send them to an ear, nose, and throat specialist first. Okay, so we did the inner ear. Now let's focus on the vestibular nerve. There's considerably more differentials here. First is going to be swelling. So I included both of these on the same slide because clinically, these, while are separate entities, are essentially indistinguishable clinically. So one of them is swelling of the otoliths themselves, and the other one is swelling of the nerve itself. So vestibular neuritis is the swelling of the nerve, and the labyrinthitis is the swelling of the labyrinth itself. And almost all of the time, this is caused by some kind of virus. So usually the person is getting better. So they've just finished their antibiotics, if they got any antibiotics at all, or their ear doesn't hurt them anymore. And then all of a sudden, bam, they get this dizziness and vertigo. Now, sometimes people like to differentiate that you can see fluid behind the tympanic membrane with vestibular neuritis, or I'm sorry, with labyrinthitis and not vestibular neuritis, which would make sense. But at the same time, this is not often seen or looked for. And so we don't know how accurate that is. So I wouldn't rely on that for your diagnosis. If somebody has recently just had some kind of viral infection, and then all of a sudden they came in with some vertigo and it looks kind of like BPPV, but their Dix-Hallpike is negative, I would probably go ahead and diagnose them with labyrinthitis or vestibular neuritis. The good news about both of these is that they're both self-limited, which means they go away in a couple of weeks. It's also good to know that you can use steroids with these if you need to. Next is Ramsey-Hunt. Ramsey-Hunt is shingles of the vestibular nerve. So that means that the shingle spots are going to pop up on the ear and inside the ear itself. This is going to have a really profound pain type response. Remember how sensitive your ear is to pain? And then think about how much more ear pain hurts than other areas. This is intensely painful, and it's often associated with dizziness and vertigo, sometimes even the hearing loss. This is more severe than Bell's palsy, and these folks need treatment for herpes zoster, but they also need a referral to ENT because these folks need to be watched to make sure this isn't going to be a long-term problem or complication. You also should go ahead and give this person some steroids for pain. Opiates are not going to help with Ramsey-Hunt syndrome, unfortunately. Next is an acoustic neuroma. Remember that even though this is not something that is as diagnosable in the emergency department, it is still a vestibular nerve problem. So here is our semicircular canals and our cochlea. And you can see here that this is our vestibular nerve that is going back here. And then this is the big, large tumor that's growing on our vestibular nerve. That tumor is causing lots of problems because the tumor itself is pushing on the cerebellum. That's causing all of our cerebellar type symptoms. So these people have a positive Romberg sign and problems with finger to nose and all of the symptoms that are usually found with a posterior stroke. This is something that usually requires an MRI or a CT with contrast to find. But again, this is not necessarily something that we're finding in the emergency department initially. This is somebody who you probably have paged out neurology for instead. Finally, we're going to get to the autotoxic drugs. Autotoxic means ear toxic. And remember that any medication, any drug, can cause dizziness. It's the number 2 side effect of any medication. And it can happen even if you've been on that medicine for over 50 years. But that being said, some medicines are worse and more significant than others. The two that are the most common and the most notorious are loop diuretics and antibiotics. These are the specific ones that I have listed here in this table, but you should know that any of the loop diuretics and any of the antibiotics can cause it. So in particular, our CHF folks, or the folks who are on loop diuretics for like lymphadenitis or swelling of the feet, or even some of our liver cirrhotic patients can get this kind of dizziness due to drugs. So remember to ask about their home medications and take a quick look because these are very often the cause. Finally, we got to ask ourselves, let me erase that circle there. Sorry about that. We got to ask ourselves, how can we help these patients? There they are, being really dizzy, walking down the hall abnormally. And even though I'm here to tell you, hey, it's just BPPV, this will go away in 2 weeks, they're going to vomit all over your shoes and say, I can't wait 2 weeks. I can't work like this. I can't live like this. We do have some treatments that can help. So notice that I've labeled them 1 through 4 here because I think that everyone should start with step 1 first. Antihistamines are for the less dramatic cases or the ones that you're not really convinced or the ones that are almost over. Meclizine, Dramamine, and Benadryl are the 3 antihistamines that seem to work the best. Meclizine is often prescribed for dizziness specifically. The brand name of Meclizine is Antivert. Dramamine is the next medicine that's usually used, and Dramamine is used for seasickness, so you can see how it would help with that abnormal movement. Only if absolutely necessary should you be using Benadryl, because we don't want to make these people sleep all day long. Next comes the Phenergan. We're not entirely sure why Phenergan works for dizziness. We just know that it usually works on the brain's interpretation of motion. So this is something that you should try out, see if it's making a difference if the antihistamines aren't. Next, number 3 is IV Valium. I want everyone to pay special attention to this one because for those patients who have a ruptured tympanic membrane, or if they have vertigo and vomiting, and no matter what medicines you give and what antihistamines you're giving, nothing works, IV Valium works like a charm. If this person has dramatic symptoms, please consider and do not be afraid of IV Valium. I myself have personally had a tympanic membrane rupture, and the dizziness was very intense. And I'm going to tell you that Dramamine and Meclizine and Phenergan did nothing. IV Valium was the only thing that worked for me, and I got 1 dose of it and was instantaneously a million times better. So it is something that you can give as a one-time dose. Please, please consider Valium. This is what the ENT folks use typically. And finally, steroids. And I put this last because not all causes of vertigo deserve steroids. If somebody has labyrinthitis or vestibular neuritis, remember the cause of the swelling, the steroids can help. But if they have something like a brain tumor or BPPV, steroids aren't going to do anything for them. So remember to think about the cause and try to figure out why you think they're dizzy and apply that to the medications that you're giving them. Now, I know that being lightheaded or feeling like you're about to pass out is not necessarily something that should go in this lecture. But I had to mention on at least just 3 little slides some of the most common things because, like I said, patients don't always know what they're feeling. So you want to keep all of these diagnoses together in your mind. I like to think about lightheadedness or syncope as 3 main causes. It's either a brain problem, a heart problem, or a metabolic problem. So if you're looking at heart problems, almost all of these can be ascertained by simple things. Things like history, an EKG, or looking at the blood pressure, okay? Then if we want to think about brain stuff, we want to do just a quick neuro exam and see how intense all of it works. If they don't have nystagmus and their neuro exam looks perfect, it's probably not a thing. And then we have the metabolic problems. Remember that things like hypoglycemia can still cause that lightheadedness feeling. So can pain or different toxins like drugs and alcohol. So can anxiety and thyroid problems. So you have a pretty wide differential, but you have a pretty tight categorization of each of them. Next is the vagovagal. I specifically bring up vasovagal because it's the safest and most likely the common cause of syncope or presyncope. This is an activation of the vagal nerve, which is cranial nerve number 10. And cranial nerve number 10 is primarily responsible for your parasympathetics. So you're going to get things like nausea, dizziness, and sweating. And usually there's two main causes. It's a stimulus induced where something has activated the vagus nerve. And this can be quite complex. It can be as simple as fear or anxiety. It can also be injury or the sight of somebody's blood or inner organs. It can also be the hormones of pregnancy that can induce this vasovagal response and cause somebody to pass out. Now, we also have our overactivation of our vagal nerve, and that can be very classically coughing too much, or there's vasovagal syncope relating to defecation, pooping, or urinating, micturition. That's very classic findings. If you have a history of somebody who's gone pee or poop and then they passed out, this is usually very reassuring and usually doesn't happen a second time. You can also have overactivation of the autonomics with chronic injuries and oversensitivities, things like POTS syndrome, but we're going to talk more about that in the neurological section. I also want you to know that if you're suspicious and you've ruled out many other big causes like posterior stroke of your syncope and your dizziness, if you're pretty convinced this is vasovagal, there's no treatment needed, and usually it doesn't occur again. I do want to point out that some people have recurrent vasovagal problems, and there is something out there called a vagal stimulator. You can see that this looks like a pacemaker, but the wire is wrapped around the vagus nerve, and it stimulates the vagus nerve to prevent further syncopization. So know that vagal nerve stimulators exist, and I'm not going to go more into those. Finally, a lot of people ask me the question, in order to differentiate between vertigo and syncope, especially those causes caused by cardiac issues, what should I be looking for on the EKG? And I wanted to include this slide because a lot of people ask me this question. So these are the things that you should be looking for specifically on an EKG. If you're not seeing one of these big obvious causes on the EKG, most likely it's not a heart problem. All right, now for our summary. So in general, we want to classify and categorize, but remember that this can be very confusing for you and the patient. So you don't want to necessarily differentiate or diagnose yourself into a corner. Remember to have a broad differential for this. Number two, always do your complete neuro exam, especially with all of your cerebellar responses, and you want to do your HINS testing. Those are also the two most important parts of your documentation for dizziness. And finally, we want to rule out those big scary causes like our posterior stroke, and we want to consult or follow up as needed. Most of these dizzy patients are going to be going home. And this is just an overall broad review. And these are some really good resources, along with another beautiful, another beautiful picked graph of all of the different differentials. Until next time.